Hello and welcome to this panel discussion on the role of IT in healthcare in the post-pandemic era. The organizers of the WCIT are especially interested in highlighting the opportunities that IT affords to make people's lives better. And so I'd like to focus today on unpacking the role of IT during the pandemic and using that experience to discuss the opportunities in the post-pandemic era. I think we've learned a lot about how IT could be used, but also about the digital divide that seems to still exist. So I hope that we can also discuss the challenges that still lie ahead in ensuring that no one is left behind in reaping the benefits of IT in the future. I have a few questions that I have provided ahead of time to the panelists, and so I will ask them those. And I also expect that this will be a discussion and I will moderate it by directing traffic. So let's dive in. Actually, before that, let me introduce all the panelists here. First, we have Dr. Bill McGee. Dr. Bill McGee Jr. is a plastic and craniofacial surgeon who founded Operation Smile in 1982 with his wife, Kathleen S. McGee, and serves as the organization's CEO. Dr. McGee has trained and mentored thousands of physicians worldwide. He has been awarded honorary doctorates from some of the finest universities worldwide, including the Karolinska Institute in Sweden in 2014. He was awarded the American Society of Plastic Surgeons Honorary Citation Award in 2014 and was given the National Medal for Peace and Friendship Among Nations in Vietnam in 2009. In 2007, UNICEF presented the McGees with a special recognition on behalf of Operation Smile, and he received the Distinguished Service Award from the American Society of Plastic Surgeons. In 2016, he stepped away from the practice to invest all of his effort and energy into Operation Smile. Welcome, Dr. McGee. Second, we have Dr. Shinjuti Saha. Dr. Shinjuti Saha is a molecular biologist and an activist based in Bangladesh. She is a scientist and director at the Child Health Research Foundation, where she works at the intersection of molecular biology and public health. After completing her PhD in molecular genetics at the University of Toronto in Canada, she moved to Bangladesh to work on the front lines of public health. Currently, she focuses on preventable pediatric infectious diseases with the goals of using modern molecular technologies, including on-site metagenomics, to identify etiologies that evade standard lab testing in resource-constrained settings, establishing genomic surveillance to track and understand the molecular basis of antimicrobial resistance in endemic bacterial pathogens, and estimating the indirect impacts of vaccines on the overall health system. Currently, she also leads a large study on tracking SARS-CoV-2 variants in Bangladesh and understanding the immediate and long-term impact of COVID-19 on Bangladeshi children. Her work is grounded in advancing health and research equity in Bangladesh and beyond. She is a member of the Polio Transition Independent Monitoring Board of the Global Polio Eradication Initiative, an associate editor of BMJ Global Health, and a section editor of PLOS Global Public Health. Welcome, Dr. Saha. Dr. Firdausi Qadri is our third panelist. She is a senior scientist, Infectious Disease Division at ICT in Dhaka, Bangladesh. She leads the Mucosal Immunology and Vaccinology Unit. Her work includes basic and applied immunology of infectious diseases, but also clinical and large field-based studies on enteric vaccines. Her special interests are infections caused by Vibrio cholerae, Shigella, ETEC, Salmonella species, and Helicobacter pylori under grants from CEDA, NIH, BMGF, USAID, University of Oxford, and the EU. The results have produced an impact in the field of enteric diseases, specifically in the area of immunological and genomic mechanisms, proteomics, metagenomics, diagnostics, and vaccine development. Recently, her research has focused on COVID-19 infections and vaccinations. She also received a number of prestigious awards, including most recently the Raymond Magsaysay Award in 2021. Welcome, Dr. Qadri. And last but definitely not least, we have Professor Nick Thompson. Dr. Thompson is a microbiologist and bioinformatician and is interested in bacterial evolution and spread with a focus on sexually transmitted and diarrheal diseases. He is also professor of bacterial genomics and evolution at the London School of Hygiene and Tropical Medicine. Dr. Thompson his lab uses genomic approaches to investigate how variation in bacterial genomes relates to their hosts and niche, changes over time and geography, or in response to therapeutic interventions. His group also focuses on accessing genome data directly from clinical samples without the need for culture. Dr. Thompson's approach to research is characterized by multidisciplinary teams of scientists, modelers, and clinicians alike, with a broad global reach and focus. At the absolute core of his work is enthusiasm, a love of investigative research, willingness to collaborate, communicate, and teach science, as well as the most important piece, a great young team of investigators, current and past. Welcome, Dr. Thompson. And I'll just introduce myself briefly so you know who I am. My name is Supriya Kumar. I'm a program officer at the Bill and Melinda Gates Foundation in Global Health, and I work on surveillance for COVID-19, cholera, and typhoid. I manage disease surveillance grants in Asia and also lead our work on low-cost surveillance tools for enteric diseases and SARS-CoV-2. Prior to joining the foundation, I was a professor at the University of Pittsburgh Graduate School of Public Health in the Department of Behavioral and Community Health Sciences, where my research was focused on health equity in pandemics. Coming from South Asia, I remain passionate about elevating the capabilities and voices of researchers based in the region, as well as promoting collaborative research in service of public health needs of the region. With that, let's dive into the panel discussion. So to get started, can I call on each of you to give some opening remarks? And if you will, would you focus on what some of your key observations have been from the pandemic that inform your view of how IT was or can be harnessed for health? Please keep your remarks to about 3 minutes. Let me start by calling on Dr. Shinjuti Saha. Dr. Saha?
Thank you. Thank you, Supriya, for all that introduction, and it is such a pleasure to be here today. I just wanted to give you a little bit of the context that I bring in and the backdrop against which I will be talking. So Supriya already mentioned I am a microbiologist, but I'm also an activist. I constantly fight for equal access to the practice and benefits of science. I believe in building capacity, engaging, educating young scientists. And really, with a team of very young scientists, what we are trying to do is use genomics to prevent infectious diseases. And when we try to do that in a country like Bangladesh, or actually for that matter anyway, I think information and technology come at various steps. It's impossible to do any of that without IT. So to give you 2 examples, when I speak of genomics, we need IT to be able to analyze the genomics data that is produced. Just one sequencing run for genomic analysis can lead to hundreds of GB of data. So how do you store that data? How do you analyze that data is helped by IT. And also, storing that complex and long data is extremely important because as we move forward, every year there are new pipelines, new ways using which we can analyze the data. So storing raw data is really important to every year reanalyze and gain insights from that data. Now, if you want to really use that genomics data to actually have clinical impact, there is another stage where IT comes in, and that is handling clinical data. If I thought genomics data is difficult, long, complex clinical data is way more complex than that. So it is only when we can connect genomics data with clinical data can we really have thoughtful impact. So we have been working throughout COVID. We work in 4 hospitals across the country, and right at the beginning of the pandemic, we have been able to utilize genomics data, for example, to quickly understand the impact of COVID-19 on neonates, the lineages that were infecting neonates in Bangladesh, etc. And really, again, all of that has been made possible because we have a really good integrated system that takes in clinical data, links that to genomic data. But we are a very small organization in Bangladesh. 10 to 15 years ago, in our IT department, there was one person who took care of everything. Now, we have a parallel IT division with multiple people helping us every step of the way. As we go forward, we think IT cannot be a division. It is something that has to be an umbrella of all other biological divisions, whether that's epidemiology or genomics, that is going to glue all the divisions together. I know we will be talking a lot about the role of IT in healthcare, so I'm going to end there with the perspective that I bring in. Thank you.
Perfect. Thank you for that, Dr. Saha. Can I call on Dr. Thompson next for your opening remarks?
I'd be happy to. Thank you very much for this opportunity. It's a real privilege to be here and to be in front of this very esteemed panel and an audience. I'm a microbiologist, a molecular microbiologist by training, who loves biology. And I see ICT as the doorway into that biology, into the excitement that you can discover, the phenomenon, the incredible insights that you can generate from looking at natural diversity in biology. So ICT is that doorway into it, and genomics just lends itself to ICT. And having spent a lot of my training working on in the laboratory, working on bacterial isolates, looking at trying to manipulate them in terms of genes and their function, in terms of phenotyping them, I realized that actually genomics at that time, and well over 20 years ago, offered a new insights in several ways. One, it changed the way I work because it provided the context to a lot of the molecular biology that I was really focused on. The backdrop, not just to understanding an individual strain or isolate, but actually the backdrop, potentially, if the technology became cheaper, and of course it has done since, a backdrop, the global backdrop, to understand diversity across huge space and time. And of course, the other key the key property of genomic data is it lends itself to being digitalized. It's a universal language that offers the ultimate resolution, and it's easy, as Dr. Saha has mentioned, you can exchange that data, you can store it, you can compress it, you can reanalyze it. As long as that data is there, you can do many different things with it. It's a universal language that really unifies our efforts, unlike a lot of the other tools that we have for exchanging biological insights, publications, word of mouth, conferences. Creating databases and data allow people to investigate different questions, equally as important questions that are equally as important and exciting to them at different times. So it's a unifying language. It's relatively cheap. Again, as Dr. Saha has mentioned, there are tools and really amazing set of disciplines and science and scientists that actually are developing those tools to really dig out the deep biology within those data. So it's multidisciplinary, again, in a way that actually we've never had before. ICT and genomics together combined brings in the disciplines, whether it be clinicians, whether it be basic scientists like myself, whether it be computer scientists, whether it be mathematicians, whether it be epidemiologists. And again, Dr. Saha spoke about clinical data and linking that to genomic data. It's the linkage. The key thing here is the linkage. And it's linkage through exchange. And so actually linking to epidemiological data is the mainstay of my work. It's critical to understanding temporal and geographic changes in pathogen transmission. And there's never been a better time to really feel how important biological insight, an understanding of epidemiology, an understanding about the basic science of an organism, the exchangeability of digital data and digital systems, metadata and clinical, or all the different data exchange, the metadata as we call it. And there's never been a better time or example of how that can power global interventions and control and basic understanding of such an important disease like COVID.
Great. Thank you for those remarks. Can I go next to Dr. McGee, please?
Let me say it's a pleasure to be here, and I've been involved with the Conference of Information Technology since 1998, and I have to thank all of you philosophically for allowing me to step into that, because I learned an incredible amount. Over the years, Operation Smile is now going on its 40th year, and we're in well over 30 countries operating on children. Each of us on this panel and each of us in so many segments of the world have our own specific skill sets that we use. But the beauty of coming together into something like this is we get to kind of open our eyes, if you would, be proud of our individual strengths, but also realize the power that everyone on this panel has and who you represent to see who we are tomorrow. Because this is about tomorrow, it's not about today. When I first stepped into this, I knew nothing about it. I still have trouble working on my computer, and if it wasn't for my assistant, I would be lost. But the reality is that what I learned through technology is phenomenal. And you know, during this pandemic, I think it opened our eyes in another whole way. Everybody became more used to communicating with one another. And I think I work harder now than I've ever worked, because it starts early in the morning and ends late at night because of the time zone changes. The reality is we've operated now on about 350,000 children around the world, but that's just the surgical element. And surgeon is only 10% of surgery. 90% of surgery is the anesthesiologist, the nurses, the pediatricians, the geneticists, the laboratory, the blood bank, the instrumentation, the equipment, the dentist. There's a wide variety of talent that goes into producing excellence. And IT allows us to merge all that in a productive way. I think that the key is that we all are looking for outcomes, and we all try to measure our outcomes. Speaking of genetics, for instance, we have the largest collection of genetic specimens of clefts in the world, about 16,000. How do we study those? How do we get the most out of that? Well, we have to go to people who have different skill sets to do that. So you get an output with your study. The output leads to outcomes. Those outcomes are what drive you to seek the next outputs. And it's a vicious cycle that you continue to do if you keep your mind open to get the outputs, and then, you know, develop a different system, and then as that system develops, see where you can perfect that system. It's a never-ending cycle, but it's been beautiful to watch. And I think that with the IT help, we can start to come up with solutions that none of us as individuals probably could have come up with. So motivation, you know, the necessities of autonomy, of mastery, and of purpose are all there. All of us have to have those. All of us have to be driven. And if we're driven together and use each other's knowledge, I think that we can create change in the next decade that could be incredible.
Great. Thank you for those comments, Dr. McGee. And Dr. Kadri, can I call on you next, please?
Thank you, Supriya. It's always not so nice to be the last in the discussion, because let me tell you, now we've talked, Shenjyoti has talked about genomics and NIC2 and the magic of IT. Let me tell you about my work. I'm basically a biochemist, immunologist, vaccinologist, and a public health person who wants to do a lot for Bangladesh. And what I have learned over the years and have fast-tracked now after COVID is that, you know, without IT, I could not have done anything. All the vaccinations, all the data, all the, you know, when you do a vaccination, you have to go into find out how many people are protected. You need passive surveillance. Gone are the old days. Now you can do many things using your tablets and your IT-based gadgets, where all the information that is collected at the field immediately gets transferred into your database. And that's the best thing that has happened to us. I can now get access to all the data that is collected in the field in real time, every day. What's happening in the field, who's getting the disease, who's protected. And so I think with IT, with the Android gadgets, the tablet, our community health workers, our field workers in vaccine studies, and also all over Bangladesh, have these gadgets in their hand. They go from place to place, and immediately it's transferred back. Now, let me tell you of a recent study. We are doing, looking at cholera and COVID in a rural area in Bangladesh. And instead of doing a ground truthing and a structural lookout for sensors and things like that, we just use the GIS satellite map in a very modern way. And our staff were there, collecting blood, but also looking at the structures without just putting things into their tablets. And then immediately it was transferred to the computers, and within minutes to our collaborators and to all our IT staff. And so, as Shejyuti said, without IT, it would have been difficult to move. All my large 3 million vaccination among the Rohingyas in Cox's Bazar, or looking at typhoid large studies that we are carrying out in urban Dhaka, or looking at large cholera vaccinations. But then we are linking this to humans, to the clinical data always, and all the antibody responses. I'm not going to go into genomics so much, but genotyping the phenomena of who reacts to vaccines, who does not. This large database of clinical data that we also have at the same time. So as I think that, with the work that we are doing now has actually expanded so much, and we are compressing a lot of data together. We are analyzing it, and COVID was no different. I think COVID made us realize that the world has changed and never will go back again. We collaborated with people we could not have thought of collaborating with in such a closed atmosphere when we were not allowed to move out of our houses, most of us. And we've worked across thousands of miles in seconds. Like it was almost like magic that we worked across institutions between Shejyuti's institution, my IDESHI and ICT-DRB. We did not hold hands before like that without ICT. Now we know how to connect with Nick, a close friend of mine. Now we are connected. And Shupriya, yourself, we've been going back and forth thinking about what to do. So COVID was no different. COVID made us so smart. I think it's a point of no return. We will be keeping on using ICT, genomics, simple tools, very sophisticated tools that can be used at the bench in any place in the country, the Minayan sequence, if I can talk about it. Also, looking at the antibody responses, it would have taken us 5 years to understand how many people are responding with antibodies. Right now, it hasn't taken us anything. We have the clinical data. We know from our database that the government has, Shurupka, who has got the vaccine, who has not got the vaccine, who has had COVID, who has not had COVID. We get real data in real time. And so I think I'm so grateful to IT. And over the years, I've learned a lot. But in this post-pandemic area, I just marvel at the beauty of how things are done so quietly and so well.
That's great, thank you. I think there's a theme of multidisciplinary science and the collaboration that the pandemic has made an opportunity really for us to harness in this post-pandemic era. I want to pick up on a theme though that I think many of you mentioned, which is the linkage of clinical data and metadata to other kinds of data. Can we pick up on that and just look at electronic health records, for example, which have been looked at for a long time. During the pandemic, there's been the necessity to link vaccination records to other kinds of clinical data. And Dr. Kadri, you mentioned that is something you've been working on for a long time in your trials. How has that come to the fore in the pandemic? Have there been challenges with that in low resource settings? And what are some opportunities for the future? And Dr. Kadri, since you went last time, maybe I can just ask you to go first this time.
Okay, thank you, Shupriya. So electronic health record is something that Bangladesh has been looking forward to, has been trying. I mean, the IT people here will tell more, but of course, electronic health records are needed. And for this, many plans are being made and some are being actually already have started. But electronic health records, I think the Shurok dashboard that we have is an example. We've already started this. It was started earlier, but we have, again fast-tracked into electronic health records now. We know so much more about our population of 170 million people. I'm sure there are many strategies for having better records of people that can be shared between different facilities. We have facilities at the periphery, we have facilities at the top level in the cities and in the districts. But we also need to merge everything together. So I think these things are being done. And again, COVID has taught us that it can be done so easily. We are just taking the products that ICT has produced for us. But it has been so useful for us to look at these data for studies on cholera, typhoid, dengue, name it. And so I think we need to do more in Bangladesh on electronic health records. A lot is being done by many organizations, including the digital health providers. I believe there are 16 in the country from what A2I gives us. And so I think that we don't have the best electronic health records yet, but it is in the making and it is very much needed.
Great, thank you. Dr. McGee, you probably have to deal with clinical records that follow individuals over time. What are your experiences, especially during the pandemic, and how do you think we're set up for the future?
There's no doubt that we have to deal with it, and there's no doubt that it's a challenge. In the surgical arena, we're blessed with, if you would, especially with cleft lip and cleft palate, a before and an after that says to the world, involvement can create change. It's a metaphor that allows us to go forward, because in as little as 45 minutes, you totally change someone's life. And people can see that immediately. The key is how do we prove what we're doing is correct? How do we make sure that we bring sophisticated health care into everybody? There's 5 million children in our world that have never had a cleft repair that need it. About 80% of our world doesn't have access to the standardized surgical health care that we take for granted a lot of times in the United States and other countries like that. And so how do we export that, if you would, into these worlds? Well, if we don't have great medical records, if we don't have great record keeping, we can't even see where we've progressed. We can't see what's worked and what hasn't worked. And so the keeping of medical records is absolutely essential. And it's an evolution. It literally never stops, I would say. And to capture that clinical data, we're working with Microsoft on that, have been for a number of years, of perfecting our medical record system. And we think we have it, and then all of a sudden we see things that we don't have, and then all of a sudden things that we can add to. So I don't think it's ever a process that stops today and say, we found the solution. I think that it just depends on who we're communicating to, what needs there exist, and then how do we use the face of a child, if you would, to say, man, it's important to do it now, because what if this were your child? Wouldn't you want it done now? There's an urgency to it that we have to accept, and we have to accept the responsibilities we have.
Yeah, absolutely. That's great. So after talking about the individual data linkage, I want to move us to thinking about higher level data, so surveillance data that might be important for a country to deal with and has really come to the fore during the pandemic. I want to call on Dr. Saha and Dr. Thompson to take these questions. Can we talk about surveillance data? What should governments be doing in order to track disease in their populations? How have you seen the linkage between genomic data and other kinds of surveillance data? And what are some challenges and opportunities that have come up? Maybe Dr. Saha first.
Sure, thank you, Supriya, again. So let's go back to what surveillance is, right? Surveillance is the cornerstone for instituting policy, evidence-based decisions for endemic diseases. At the same time, surveillance is also required in ideal cases to forecast epidemics. So early detection that can tell us about epidemics that are coming so we can prevent them. So when we look at surveillance in that way, I think during the COVID pandemic in Bangladesh, we have learned quite a bit about it. For example, and Bangladesh has really been an example in sharing data. Right? From the very beginning, every day the public had access to number of cases, number of deaths. There are these dashboards that are maintained by the government where we could see everyday cases. Not only cases, during the second and third wave, we even had access to the number of beds available in a hospital, ICU beds, general beds, so that the public knew where to go, where to look for a bed, and or where not to look for a bed because the hospital is already full. In addition to the government, we also saw a lot of smaller private organizations come up and do fill gaps that there were. For example, we were able to see how many in primary healthcare facilities, how many oxygen cylinders are remaining. And if there were not enough oxygen cylinders, there were the general public who could get together and transfer oxygen cylinders to where there was a need. Then as we moved forward, the data on COVID-19 got more granular. We had district level data, and that came in so handy during the third wave. Now, of course, there was genomics data that told us from the very beginning that there was Delta circulating or being introduced in the country. But because of the district level data, when we saw the spike of cases, we knew that they were mainly in the western districts. And we knew there was Delta circulating in India. So very, very quickly with that data, our policymakers were able to institute a lot of evidence-based decisions. Now, yes, of course, we were not able to block the entire wave, but we have been able to definitely prevent many, many cases because we have that publicly available data. Now, going forward, data is just not enough. Right? Having data, having access to data is one thing, but being able to analyze that data and making inferences based on data is another thing. And that is where I think we still have a long, long way to go. We have to think about who has access to that data, who is analyzing that data. Even if the government is generating that data, can scientists, basic scientists from private institutions access that data, analyze that data, make real-time inferences. Some work has been done in the country, some of which has been in collaboration with high-income countries, and that's great. However, I think it's important that if we are really wanting to use surveillance data to fulfill the main need of real-time implementation of decisions, forecasting epidemics, we need to build in-country capacity to analyze data and to make inferences as we go forward. Otherwise, only data is not very useful going forward.
That's great. I heard the same theme of the evolution of IT over time come up that Dr. McGee had mentioned. We'll come back to that. But Dr. Thompson, over to you.
Thank you. Yeah, I think there are very strong themes, and COVID, I think, has really stress tested not just our existing systems, but also our real determination actually to see the value in linking those systems. And so in the UK, we have electronic health records under NHS Digital. And this is a long-term exercise. It actually began in about 2005, before NHS Digital became, as it's branded now, in about 2016. And the idea, of course, from the UK side, and I'm a user of the data. I don't represent NHS Digital. Just simply fascinated how effective it's been over the last year and a half in bringing together different data types that actually are relevant for an epidemic. But the idea, of course, in the UK is to go paperless. And what does that really mean? It means that you can have systems that can cope with the type of data and information that Bill and Senjuti are talking about. Some of those are actually pretty fine scale data. Some of them relate to individuals and some of them are generic concepts across populations. And we have to work out how to capture the relevant pieces, the high value pieces of information that are relevant to tackling something like COVID control. So in the UK, we have NHS Spine, and that actually handles about It's 3.5 messages a second, 41 million messages a day, and it contains 65 million summary care records. So these become, you know, if you're purely a computer scientist, suddenly your eyes light up, because actually there's power. If you're a mathematician, statistical power comes from linking data types. We've not had that in the way that we do now, and COVID's really driven that. And so we actually have specialised, so SGSS, which is the second generation surveillance system within the UK, was really instituted in response to our track and trace and also our genomic sequencing to link data to patient records, so and also to patient outcomes, treatments. We have the NHS Business Service Authority, which links all of the personal level information. 54 million people on the records, 2.3 billion records. And this really starts to become an integrated system where we also have the NHS immunisation and management system. And so suddenly what you need, I think, are all of those systems to be able to come together to link that data and then allow both work to things like service and monitoring. You know, is our PPE in the right place? And again, I'm picking up on some of the comments the panelists said earlier about free beds. But also actually links into intervention as well. And one of the real huge leap forwards we've had in the last year and a half is to empower research. And again, this links to the multidisciplinary theme. But it also acknowledges that sensitivity around data. And so actually, data scientists have been thinking about data security, data movement, and associated with security for a long time. And there's some very skilled people. And so in the UK, we've actually developed trusted research environments, which actually really have very defined principles about where they are, how data is moved and stored, and it's minimizing data movement, which tends to be insecure. It has 5 overarching principles about the people who can access the data and the type of work they can do. It really screws down governing the type of research, and it limits the number of questions that can be asked. And it has that public face as well. It's transparent, it's secure, and it really starts to think about what we really need to know. So it's data rich, demographic data, clinical data, as well as actually genomic data. And so it's a revolution. It means that actually research scientists, clinicians, epidemiologists, modelers, computer scientists truly can ask those bigger questions. And in the past, that's been difficult. You had to access those records individually. There was expense and time associated with getting into those and accessing those records. Wholesale change has been driven by COVID. There is no better time to be interested in ICT.
Great. I do want to focus in on Bangladesh and the role of A2I specifically over there. But before going there, I want to call on Dr. Kadri to see if she wants to also weigh in on this question of surveillance. And let me add another little bit of complexity to the question. Can you also talk about surveillance data, not only in one country, but across borders? What has your role, what has your experience been, and what can IT do to help with some of the quite deep challenges that we face across sharing data across borders?
Yeah, so Shupriya, thank you. First, surveillance. I think nothing could have been achieved what I've done without surveillance data. Surveillance for me is giving a vaccine and then looking for who gets the disease, who doesn't get the disease. Without that, I would never be able to measure the efficacy of a vaccine, the effectiveness. So that's the neatness of the surveillance data, the completeness of the surveillance data is absolutely essential to genomic, clinical, vaccine, everything. And so that's fundamental. And I think many countries lack that. Countries which lack a strong ICT system lack that and never reproduce anything that can be done. So for me, without ICT, it's very difficult. But if I want to talk about the role of A2I, access to information. I think I learned about it actually during the COVID times. If I go into the story about how we could understand about progression of COVID, if I'm allowed to do it with this question, Supriya. So we were actually looking at SARS-CoV-2 in Bangladesh. We were working with so many institutions, IDCR, ICT, IDESHI, especially the National Institute, IDCR, which has the resources, which has responsible for surveillance all over the country for every disease. And with that were the specimens. And with those specimens, we could actually track, we could see what was happening. We had the genomic database. We had the MinION sequencer, which thankfully, before the pandemic, we had a big cholera conference, and we had one MinION left in our lab, which is a very low-cost sequencer. Does not need too much experience, but you can handle it. And so with that, we used the information from A to I. We looked at surveillance data from the IDCR. We tracked SARS-CoV-2 all over Bangladesh. We could, because samples were coming from all over Bangladesh to this National Institute. And from there, we knew where we were getting the different variants of, we were getting SARS-CoV-2 at that time, not only variants. This was as early as March to April, when the pandemic was first struck. We could also look at the first isolate that came to Bangladesh, March 8th. We could track that, and we could see, because of the long national holiday that was given, the Eid holidays that came after that, we saw how the progression came from Dhaka city to all over Bangladesh. And what we did was, because of the beauty of IT, we sequenced everything. We got the bioinformatics done, having a zoom camera and having the sequences transferred. We learned, we worked with different universities, different institutions in Bangladesh, National International University of Bath, with Harvard, and with Nick Thompson at Sanger, and also the National Institutes. And we very quickly produced, not very quickly, but we did produce the best data, one of the best data. Shenjyoti has very good data. One of the best data that came up showing that how SARS has spread. And now we are with, thanks to Supriya and the team, we now have a nationwide surveillance, which is because of what we were doing. And this was such partnership. All the institutions were working separately but together, because all the data was going into WCIT. Everybody knew what was being sequencing, whether we had the Wuhan type and then how it progressed to alpha, beta, delta. And so I think we learned from COVID to work together. The surveillance was so important that finally we got a grant where all the institutions are working together. We did not have much money, but we had ideas. And we had the capacity because of IT. I think without IT, we would be sitting in our homes. There was lockdown. Many people could not go to work, but we did everything. And I think, as you said, Supriya, I think data for surveillance of all kinds, clinical, vaccine, passive surveillance, and genomic surveillance. Everything has to come together to understand a disease that's spread. And what COVID has taught us is something we will never forget. We will go on marching, and Bangladesh always is the first to do great things, and we will do it.
That's great. I think you've laid it out very well for our next topic, which I really want to dive into, to the role of A2I in Bangladesh. I think, even for me, during the pandemic, I've gotten to know them, and they are quite an exceptional group, very well supported by the government, and quite unique, I think, in the low resource settings especially, but unique in many ways across the globe. They're, I think, a shining example of what is possible with limited resources. And I want to sort of discuss with you all, what are the opportunities that A2I provides to better the health of Bangladeshis? And what are your hopes for the next 10 years? Dr. McGee, maybe I could start with you. You mentioned sort of the need to track before, after, data on the individual. and that IT continues to evolve over time. Can I go to you first and ask you, for Bangladesh and low resource settings like that, what are your hopes for the future?
Well, I think that in all low resource settings, the key is to get to the leaders, both of industry, in government, and in every aspect of a society. Sales is so important no matter what profession you're in. We're all sales people. And I think that if we can enhance safe surgical care into the district hospitals, we enhance everything that's associated with that, every aspect, whether it's the collection of data, whether it's the use of that data, or whatever specialty it is. We need the support of the political and the business leaders. What I have found over the years is that nobody's prejudiced against a child. A child is not black, white, Asian, Latino, Muslim, Christian, Jew, Buddhist, Hindu. A child is a child. And if you see a child that needs help, boy, it's easy to attract the attention of the individuals you're talking to. And change occurs because of emotion, not logic. We all logically know what's right and wrong. But if you can touch people, if you can put a tear in their eye, then they'll start listening to you. And I think that emotion is what really leads to change. Because if you can put that tear in their eye, then the person is going to listen to you about the data that you have to be able to justify what you're saying. And life is a sales job, and we need to do it. The other thing is that women are huge for the future. Absolutely huge. We had a complete women's mission in Morocco, where we operate on about 180 children. I am telling you, every one of those volunteers was women, and it was powerful. In the coming year, we're going to try and establish 4 complete women's missions in different sectors around the world to draw the attention to the power of women and how much they can add to the healthcare industry. Data really is important. And you need to use that data to make our point once we have people's attention. I think knowledge and science are crucial, of course, but knowledge alone will not suffice. It has no heart. No amount of knowledge is going to nurture or sustain your spirit. It's never going to provide you ultimate happiness or peace. It's only when our knowledge is infused with intense passion and energy that knowledge then has a chance to come to life. And we've got to realize that. We've got to realize that the stories of the people that you're helping are what's going to attract attention and keep the memory.
Yeah, powerful comments. Thank you. So women and children are a way to attract resources. Can I go to Dr. Saha? I know some of your work is in the maternal child health realm of things. What do you see as our learnings from the pandemic that could be taken to some of the diseases that do impact children more? Infectious diseases like SARS-CoV-2 seem to impact more the older ages, but what about the infections that affect neonates and children? Can you speak to the role for A2I in the future for that, Dr. Saha?
Thank you, Supriya. I will get to the specific, but before I even get to A2I, I want to bring in a little bit of history, something that we were speaking about right before this panel, that we talk about digital Bangladesh all the time. The digitization that we have seen in Bangladesh is absolutely incredible, and I think I can say that because I lived in Canada for 11 years, I've lived in the UK, I've even spent some time in San Francisco, but really with this phone, the amount of technology that I have at my fingertips in Bangladesh is unparalleled. And I will tell you, what I'm wearing right now is a sari, and I wear a sari to work every day, and all of them have been bought from e-commerce sites by, led by women, and all of these were delivered to my doorsteps because of the digitization that we are seeing at the moment from local artists. And we see that even for delivery of any other household products. So I think what we are experiencing in Bangladesh is absolutely incredible, but the perhaps what we feel who are in health is that digitization is not reflected in health. There are still many gaps, and some of the gaps that we have already spoken about. There are resources, and definitely a very inspiring, resourceful entity is A2I, and they're definitely aspiring to innovate, just as their name suggests. And they have been extremely resourceful with their data, with how they're analyzing the data, giving access to data. And there are other resources in Bangladesh too. And really, sometimes I feel it's not the resource always that's the problem. Bangladesh generates about 10,000 doctors per year. In theory, for every 6,000 people in Bangladesh, there is a primary healthcare system where children can go and access care. But you talked about children and accessing care even during COVID. What we have experienced that it's often not the resources but the system that bring the resources together, communication between different parts or different resources. What we often found is while A2I is absolutely amazing, if you even just talk to some of the healthcare workers, how many basic scientists are actually using the data from A2I in Bangladesh to analyze data, drive their decisions? How many clinicians are using that data to, let's say, make empirical decisions? So I think while there are many resources, there is this huge gaps and silos in communication. We saw that during COVID, when children, because there was this idea right at the beginning that perhaps COVID is not prevalent in children at all. So we saw this huge neglect in pediatric diseases. There was a dip in vaccination work. We were seeing a lot of children being refused from hospitals, if they were sick, or some of the hospitals were just closed. And I think it was, again, not lack of hospital beds, not lack of doctors, but because the systems, the resources weren't talking to each other. Going forward, it's going to be important to bring about systematic changes to tackle some of this, to ensure that even within healthcare practitioners, we talk to each other. And I'm sure Dr. Kadri will agree that in Bangladesh, oftentimes it is assumed that a diagnostic laboratory will be led by a person from a medical background. But we saw that during COVID, a lot of that changed. From one qPCR lab, we went to more than 200 qPCR labs across the country because basic scientists came forward. And it was microbiologists, biochemists who have been running a lot of these labs. But traditionally, historically, these microbiologists and doctors haven't talked. So I'm really hoping a lot of these changes as we move forward. We also communicate well with our nurses, who has been giving us extraordinary service during COVID-19, but is often not brought into conversations. So I think going forward, we have to think about not only resources, but how we connect the resources, how we have system that utilizes the resources optimally.
Yeah. What I'm hearing is that A2I has set us up well for a lot of data, and now those data need to be analyzed and need to bring together many multidisciplinary people again to analyze those data. And this gets back to a point, I think, Dr. Thompson, that you also mentioned, that the UK is collecting different kinds of data and has put in a lot of thought into what data need to be collected and how they are, what the architecture is, so that basic scientists can actually mine those. Would you like to speak to how we can ensure that the types of data architecture that you are using now in the UK are transferred, the technology is transferred in a timely manner to Bangladesh, and also the hopes that you have from A2I?
So firstly, thank you very much. No, I would love to. I think that I agree with so many of the comments that have been made by the panelists, and it's difficult not to be fairly inspired by the sort of passion, even on the stage. And of course, I'm I'm sat here looking into a camera on an innocuous laptop, sat here on a cold London's day. So the linkage is critical, and the one thing that you understand, you can collect enormous amounts of data, and there are obvious data types that you need to collect: immunization, test records for microbes, for bacteria. You need to look at antimicrobial resistance data. You need patient records, GP. So our general practitioner is our local doctors, prescribing practices, behavioural change, whether people smoke, whether they have underlying comorbidities. So data itself needs to be rich. And I think the systems, and that's the same, that's a universal, right? That's just universal. That's, when we're tackling infectious disease, it doesn't matter where you are, those are universal truths. If you want to affect change, the level and richness of data you need relates, it can be changed per country, it can be changed per region. But actually, there are some parts of that data, like GIS coordinates that Professor Kadri was talking about, date, time, basic demographic data, the type of pathogen, genomic data on lineage. We know the importance of knowing the Delta variant versus the Alpha variant, for example, in COVID. So we know the type of data we need to collect, and that's universal. Microbes don't respect borders, so actually there's a real drive. You can provision all you like nationally, but actually in truth, microbes spread as people move, sometimes airborne, sometimes by touch, sometimes by other means, by water and so on. So we know that actually we have to think beyond our own borders, and that suddenly is again leveling. It's that unifying, ICT being that unifying language. I think that what I've seen is the prestige it brings to be part of your national effort to control disease. And I've seen that in Bangladesh many, many times. And I was privileged to work with Professor Kadri and Professor Shirin on the response to COVID in Bangladesh. And what did that mean? It meant that everything we had, from the SOPs, the risk assessments for working on live COVID, were exchangeable. We have the same risks, we often have exactly the same equipment, and we have the same concerns and worries. So it unified us in that sense. The prestige, and picking up on Professor McGee's comments about emotion and data having no soul, to me, of course it's absolutely right. It can be written down in a page and forgotten, and it takes people to really give the voice to that data. And as I say, I've seen people in Bangladesh, and I've also seen people across Latin America who are involved in national efforts. And so what we need to do is to harness that emotion. What we don't want to do is to reinvent. And actually ICT, just like in the lab, 90% of the lab time can be making up reagents and doing experiments, and only 10% is that sort of light bulb moment, that flash bang wallop of, wow, that's amazing. And ICT can be the same. So what we need to do is to reuse, repurpose. We'll need to edit, because actually there are big differences in the types of data, the acceptability of different data in different settings, and that engagement with the public is something that I think A2I has really led. It shows that innovation is not restricted by budget or geography. A2I is truly innovative and brings digital data to people. And I think, so reusing, linking through all the tools that we currently have and we work through, and addressing a shared problem like COVID, it brings all of us closer to global control. It brings, I think, non-scientists, non-clinicians, non-epidemiologists closer. I have an app on my phone from the NHS. I can see my medical health records and I can see COVID data. So I think it brings people in closer to science, to public health, and to data. And just like A2I, it says we want ownership of this, and we want to then start to influence the questions. Are they appropriate? Are there qualitative questions that patients, long COVID, for example, debilitation, it's not just the metrics that we record on the clinical side. It brings the public, normal people, like myself, closer to being able to influence policy and politics. And so I think it's all of those things. We need to bring ICT needs to bring people closer to the data from all forms. We need not to reinvent, we need to reuse. We need to harness the emotion that spoke about, the emotional, the prestige that we have all had from being involved in our national response efforts. And we then need to base that on exchangeable data, genomic and ICT.
Yeah, thanks, Dr. Thompson. We are coming to the end of time, but I want to call on Dr. Kadri to see if she wants to weigh in on this question as well. I think what we've heard is the need to bring in sort of the stories behind the data, and how do you bring those basic researchers, the social scientists, into the analysis? Are there opportunities to do that in Bangladesh that you see for the future, Dr. Kadri?
I think that's a difficult question, Supriya. First of all, I mean, I think what Professor Maggie said about compassion and the feeling for the data. I mean, without that, data doesn't mean anything. You have to think about it with a reason why you want it. You want people to be well. You want the country to prosper, and that is why you analyze the data. You support the incentives of the country. We being a developing country, two women over here are always thinking of ways that we can improve our capacity and assure people of what's happening. So I think data is, if that's the question you ask me, data is immense, data is big, data is great, but we need to understand data. And with that, we need a lot of training in accessing data in Bangladesh. We are having ICT spreading all over the country. We need training on ICT. We need people at the grass level knowing how to access this data. I mean, everybody cannot get into Shurokkha and understand how much vaccination has been done. I think we have all this data, I'm not right though. There is data on the phones, on the smartphones that you and I have, but I'm not sure how everything is reached everywhere. But definitely more education is needed. More privacy is needed. I mean, data policy, data privacy is needed. And a few other things to take us forward into 2030s. I think with that, I think without ICT, we would not prosper. Bangladesh would not have come so far, nor would the world, and COVID would have killed many more people. It was because of that that we have gone where we are. And it's a point of no return. We will go on further emerging infections. Thank you.
That's great. I think it's been a fascinating set of comments from all of you, and a really nice discussion. I want to thank you all for joining. And just sort of say that I think all of you will join me in being very hopeful for the future in Bangladesh. I think we're set up with tons of data at our fingertips, and it's time for us to start thinking about how we train individuals and bring in multidisciplinary teams to really access that data, give access to the public, and harness the power of the data for the future. So with that, let me thank you all, and thank the organizers also for giving me the opportunity to moderate this wonderful panel. Thank you.
Thank you. It's been a pleasure.
Pleasure.
Thanks, Dr. McGee.
Thank you very much.